Okay, let's just pick it up from here. So since COPD is a chronic condition and the changes both in chronic bronchitis and emphysema causes pulmonary hypertension, this imposes a harder or a greater workload on the right side of the heart, whose job is to pump blood to the pulmonary arteries, correct? To get oxygen, and then after that it returns to the heart on the left side from the lungs. Since there is pulmonary hypertension, so the complications, of course, are long-term will be right side heart failure arising from pulmonary hypertension. The term for this to distinguish it from right side heart failure caused by other means, we call the right side heart failure caused by COPD as cor pulmonale. Okay, so this one, if you look at the signs and symptoms, really identical to right side heart failure. The problem is the difference is the treatment. Patient will still receive right side heart failure treatment, just like any other heart failure patient. However, because the cause is what's causing this right side heart failure? It's the COPD, correct? So therefore, will we need to treat COPD at the same time? Correct.
Yes,
Correct.
Professor.
All right. So these are the other complications, because these patients will have exacerbations, especially in the fall when the weather changes. So they'll come in for hospitalization repeatedly. It's almost every year. So they are, because of the changes, because of the increased viscosity and amount of the mucus of the secretions they are making. So they're prone to infections, like COVID, for instance. They get pneumonia easily or other respiratory conditions, right? And the lung collapse will be chronic because of the large amount of mucus. They are prone to spontaneous pneumothorax. These people will develop something called BLEBS, B-L-E-B-E, which will cause them to rupture. And then when they rupture, then that will cause a pneumothorax. Management, as I mentioned last week, will be similar to asthma patients. The drug therapy will be almost identical. First, let's do prevention first. So what's the number one cause or risk factor for COPD?
Smoking.
Okay.
Smoking.
Therefore, number one prevention will be, of course, smoking cessation. As far as how to stop smoking, we do have several support. We have different methods. They are all mentioned in this paragraph right here. Okay, please read them on their own. Just provide support, and you will hear the response from these patients that say, no, I'd like to keep smoking, thank you. But always persist. Okay, so with every admission, no matter how many times you've said it, repeat it anyway. Okay. And we discussed this last week with oxygen therapy. So how much oxygen are we supposed to give patients with COPD?
90.
90 what?
Enough to reach 90%.
Okay, all right. So is there a maximum or a minimum?
I believe it's 2 liters.
Okay, so minimum is 2 liters. However, we're not restricted to 2 liters. If the patient, this is during an acute episode, okay? So we discussed last week with signs and symptoms of an exacerbation. So if the patient is having an acute attack, we can give them more than 2 liters, enough to reach a goal of 90%. Other books will say 88 to 92%, but 90% is good for COPD patients. And as I mentioned last week, we don't leave them at a high oxygen delivery device. Of course, once the acute episode is over, then we drop them back down. Do you understand the word titrate? Titrate.
Yeah.
Okay, what does that mean?
It's like increasing something as you go along, like titrating it, increasing the dosage.
The correct term would be adjusting. Okay, so because,
Adjusting.
yeah, because you don't just keep increasing, you can also decrease.
Not increasing, adjusting. Yeah, adjusting, sorry.
The titrating means adjusting the dose. Okay, so if you're at 2 liters and then you increase it to 4 and 6, and then the patient got better, no more symptoms, please drop them back down to 2. Okay. Because oxygen, remember, is just like any other drug. It has to be regulated. Complications we already mentioned earlier. And we discussed this last week. So what am I testing again on this table?
The C, the FV something.
Okay, so how much is, basically, I need to know whether you know what device to use for which order. So it'll be column number 2. Okay, column number 2, and it would also help if you know column number 3. So for each delivery device, for instance, for a nasal cannula, what's the maximum? 6 liters, right? If the doctor orders, let's say 8, what device will you use? Can you use the cannula?
No.
No.
Do we use non-rebreather?
Well, non-rebreather is already 10 to 15. Okay, so that's not really, I mean, you can if it needs to be used, but then not really, don't go for the non-rebreather right away, okay? Unless the patient is really in severe acute or acute respiratory distress.
Professor, I'm sorry, what about an high flow?
Okay, high flow oxygen that came about during COVID, that came out in 2020. They are still via the nose. They are a modified form of nasal cannula, but unlike nasal cannula wherein the flow rate is up to 6 liters, the high flow oxygen can deliver more than 6 liters per minute. Does that make sense? But the delivery is just through the nose. However, it requires a machine, not a...
So we use a BiPAP?
Yeah, 649. Beach.
Again? How did BiPAP come about here? BiPAP is different. Okay, we'll discuss BiPAP another time. All right. Because BiPAP is a positive pressure device. Okay, it's different. It's not a regular oxygen delivery system. Okay, so there's a specific indication for BiPAP and CPAP. Again, we'll discuss that another time. So here's the drug therapy. I mentioned SABA and LABA last week. For the drugs, let's go to asthma. Okay, so this is table 20-5. Here it says asthma. However, the medications also apply to COPD patients. So here are your SABAs. Albuterol is your short-acting. When we say beta-2 adrenergic agonist, so therefore, what does it do versus a beta-2 adrenergic blocker? What's the difference between the two?
Open up the airway.
As far as how does the drug work?
Better agonist is a bronchodilator.
Correct. Yeah, these are all bronchodilators on this list. However, how does it work? So when it says beta-2 adrenergic agonist, and in heart failure, we talked about beta-2 adrenergic blockers. What's the difference between these two types of drugs? What's the difference between an agonist and an antagonist? So if a beta blocker like metoprolol suppresses the sympathetic nervous system, what does this do when it's an agonist?
It doesn't suppress.
It
Doesn't
reduces the
suppress it?
symptoms, right?
It does the opposite of
Opens it
suppress.
up.
It
Doesn't
does the opposite of a blocker. If a blocker suppresses it, this one will promote sympathetic nervous system. So this is how it opens the airways. So it promotes bronchodilation via vasoconstriction. So if it constricts the blood vessels, remember the airway, as we saw the picture last week on under chronic bronchitis. So the bronchial tree, the bronchus is a muscle, correct? So you remember that picture wherein it was supposed to be wide, and then the lumen narrowed because of inflammation. So this will prevent it. So if you give the patient a beta-2 adrenergic agonist like albuterol, it promotes sympathetic nervous system activation, causing vasoconstriction, but promotes bronchodilation. That's why look at the side effects. So if you give a patient something that will promote sympathetic nervous system, what are the side effects? That's why you see these side effects here. So the patient will have fight or flight symptoms. So the patient will have tachycardia, tremors, shaking, nervousness, right? So these are the effects of albuterol. And we have anticholinergics. Also has these, because it's an anticholinergic, of course, it will cause dry mouth, urinary retention, etc. So that's ipratropium, albuterol, ipratropium. We can also have duoneb via nebulizer. So that will combine both drugs, albuterol and ipratropium, in one nebulizer treatment. Then we have steroids. So different methods of giving steroids for our COPD patients. We have systemic, which are oral, and or prednisolone also, which is given IV. So that's also systemic. And we have inhaled corticosteroids. The benefit of this is it's not really systemic. So it only delivers the steroids in the patient's airway. So here are the steroids. We'll talk about how to use the MDI and the dry powder inhalers and the PMDIs later. Here are the steroids. With every drug chart, by the way, on any chapter, the most testable part is always the nursing implication. right? Nursing considerations. It's the questions will always be about what are your nursing responsibilities, okay? And common side effects like this one I mentioned earlier. And with anticholinergics, again, this is not specific or exclusively only for ipratropium. It's for any anticholinergic agent, because there are different ways to deliver anticholinergics. This is an inhaled anticholinergic. We have oral, and we also have IV anticholinergics, but the effects are the same because they're all anticholinergics. So here are your nursing responsibilities for those contraindications. Atropine is an anticholinergic. You cannot give anticholinergics to people with glaucoma because it causes fluid retention, and that will exacerbate the condition. We'll talk about glaucoma on the last few weeks of the semester. And as steroids, what do we do with steroids again? Can we stop them abruptly?
No, titrate
No.
it.
Okay, we always wean them off, correct? The reason for that is it can actually lead to adrenal crisis. So it's dangerous. The patient can possibly die from hypotension, hypoglycemia, and hyperkalemia. We'll talk about adrenal crisis next semester. And here are because these are these taken long term or once in a while? For COPD patients?
Long term.
A long term, okay. So because it's long term, can there be, I know this is inhaled and some of them are IV. However, is there still systemic absorption even if it's inhaled?
Yes.
Yes.
Yes. So long-term steroid therapy, taken together, these manifestations are called Cushing syndrome. Also, we'll talk about Cushing syndrome next semester, but these are the common effects of steroids. How many of you here have tried taking steroids for about 2 weeks for upper respiratory infection or something? Do you remember having these manifestations, even for just 2 weeks of steroids? Okay, anyway, well, we'll talk about these next semester, Cushing syndrome. But for the exam, of course, this is here, so that's also testable. And here are other steroids. So these are long-term, meaning whether or not the patient has symptoms, the patients will be taking these drugs on a regular basis to control their symptoms, to prevent exacerbations. But because these are all inhalers, so it's really important how to teach the patient how to use the inhalers correctly. Here are steroids again. Here are LABAs, a long-acting. Again, this is not used. When we say LABA, these are controller medications. These will not help the patient during acute episodes because they're not fast-acting. They are long-acting. So therefore, the onset of action is slow. However, the effects are long-term. So they have long durations, but doesn't have any acute onset. Okay, so they're useless if they use them during an acute episode of shortness of breath. Few people are still using theophylline. Theophylline is a very old medication for asthma and COPD. However, they're not very popular anymore because other drugs, more modern medications are now on the market. but very few people are still prescribed theophylline. This is another long-term long-acting bronchodilator. And we have combinations so that you get both. For example, this is a very popular combination. This is called Advair. The dosing is usually 250-50, meaning 250 of fluticasone and 50 of salmeterol. So fluticasone is a steroid because it ends at the zone, and this is a bronchodilator, okay, salmeterol. And here are other combinations. This is a maintenance medication, Montelukast, available 10 milligrams for adults. This is PO, usually taken at the evening meal, okay, because it's once daily. Usually, yeah, before dinner. The benefit of these is, unlike steroids, wherein steroids inhibit everything, the benefit of these is they are specifically targeting only leukotriene. This is a specific type of white blood cell responsible for the symptoms or manifestations of COPD or asthma, the inflammation. So they target only leukotriene. So they have less side effects compared to steroids. These are now injectables. I'm not testing these. These are administered only, or subcutaneous as well, only in a doctor's office. We typically don't administer these. Okay. Any questions on the medications? Okay, let's go back here. So as I said, if the patient only complies with the medications, it should cut down on the exacerbations. So they'll have less hospitalizations as a result. Okay. Let's take a short break. When we come back, let's discuss how to administer how to use the inhalers. Okay. Come back at 9:43.